Good morning, everyone. Peter just told us a little bit about when this law was passed. So the law was passed, and it was challenged in the Supreme Court. And during that Supreme Court challenge, I was actually on a very expensive vacation in Hawaii that my wife had planned and, frankly, overspent for radically. And then I found out the law was going to be affirmed. And I thought, okay, we all have to stop eating and drinking now because I'm going to be unemployed within the next 12 months because we thought everything's going to the government. Well, that hasn't happened. I'm glad to still be employed. Hopefully we'll have another Hawaii vacation at some point in time. However, the government's role in health care has continued to increase since the passage of the Medicare-Medicaid Act back in the 60s. I was talking to Barb this morning, and we talked a little bit about we're all going to survive this law. We're all going to have a lot of consternation while it's done. When Medicare was passed, it was a revolutionary intervention by the government in healthcare. Really, it was the government now becoming a payer of bills in the healthcare space. When ERISA was passed, we all thought, oh my goodness, what's going to happen? Businesses won't survive. Less so with COBRA. We had COBRA passed, and again, now we're saying we got to continue to provide benefits to employees who don't work for us anymore. That was ludicrous. Then we had HIPAA. Again, HIPAA was an interesting law. It created all kinds of havoc in our businesses, but we're all surviving it. Medicare Part D came along. Again, similar consternation. Employers, what's my involvement? What does creditable coverage mean? What is all this stuff? But we survived it. And I promise you we will survive the Affordable Care Act. So for those of you that are concerned, confused, wondering what the heck's going on, hopefully we're going to shed a little bit of light on that for you today. But I promise you we will survive the Affordable Care Act. Let's talk about access to health insurance today. 55.3% of us get our health coverage, and I'm saying coverage because the payment mechanism, obviously, typically we transfer that risk either to an insurance company or through a self-insured plan, but 55.3% of us get our health insurance or health care paid for by an employer-based plan. 15.9% is Medicaid, 14.5% is Medicare. Yes, there are still 16% of us that don't have insurance. This act was really directed at many of those people who either don't have access to or don't have the ability to afford insurance. The Affordable Care Act, as it's called, isn't really that, but we're working on it. And then obviously 9.8% of us are either individuals or small businesses who buy it in the individual marketplace. The Affordable Care Act is going to radically impact the individual marketplace as well. So as you can see, still the vast majority of us get our health insurance or health care paid for through an employer-based plan. That is going to change pretty radically with the aging of the baby boomers into the Medicare generation. So this pie chart's going to look very, very different in 2020. Where'd it go? There it is. It's always good to see the United States at the top. Not so much in this case. Healthcare spending per capita in the U.S., right around $8,000. If you look at us compared to all the other countries, anybody good at flag recognition? We got Germany and Korea and Sweden and some others up there. We lead the pack, but not necessarily in a good way. If you look at GDP per capita, we're pretty productive as a country, not quite the most productive, but as a ratio of GDP to what we spend, we are by far and away the highest. Is that a good thing or a bad thing? Well, we don't have the best results in healthcare, as everybody knows, but we have pretty good results. Morbidity and mortality in America continue to decrease, but we have some pretty significant health issues that we have to get after. I think every single presentation that everybody gives should have a call to action. I'm going to have a call to action for all of you in this room by the end of the presentation, but it really is going to be around something I like to call personal responsibility. Every one of us have a responsibility to do the best we can, not just for ourselves, but for our employees, those of us that are employers, and for our really fellow human beings. Obesity in the United States is pushing 35%. 16.1% of us smoke. We deliver a lot of imaging. Anybody in the room not ever had a CAT scan or an MRI? If you've never had a CAT scan or an MRI, please raise your hand. Look around. 3/4 of the room has received some very expensive imaging. I had my son in the ER literally on Sunday. He's a football player, went down, little injury. First thing they do when you roll into the doors of the ER is, oh, we got to get a CAT scan. being in the business that I'm in, I pushed back and said, can we get an x-ray first? They did reluctantly agree to the x-ray, which, by the way, was inconclusive, and they had to do the CAT scan anyway. Good news, CAT scan was negative. He's fine. He's got to sit out a week, but he'll be back. The challenges that we face, obviously, many of them are very controllable and very driven by lifestyles that we choose to live as Americans. Again, obesity is probably the #1 health issue right alongside of smoking. As you can see in the rest of those flags that you saw up there are organized through something called the OECD, the Organized Economic Council for Development. Statistics not nearly as dire in other places, although smoking is still pretty rampant in Europe. They like to smoke over there. But as you can see, most of these statistics, life expectancy at age 65, so we're living about 20 years, the rest of the world's living 20 and a half, not substantially different. So we're getting essentially the same result, but we're spending a whole bunch more money here in America to do it. So I would propose that reform is necessary. Not a huge fan of how it was done, but again, I promise we will get through it. Just real quick, Peter kind of told us a little bit about this already, but March 23rd, 2010, the law was signed. June 28th, when I was in Hawaii with my family, the Supreme Court ruled. I got depressed. July 22nd, the Treasury announcement came out that we were going to begin the implementation process. We were all racing forward for this magical date of January 1st, 2014, at which time all of us as employers, big or small, have new things to deal with, new responsibilities. And then all of a sudden, just about a month ago, the administration put the brakes on pretty hard and said, yeah, it's not fair, it's not ready, let's put off what we call the shared responsibility piece of the law. That's the part that says you as a large employer must sponsor a health insurance plan or pay a tax, and you as an employee must purchase insurance or pay a tax, you as an American citizen. That part, guys, has not been delayed. So there is a responsibility. Everybody in the room, if you're a citizen of the United States, and if you're a legal alien here, must have health insurance January 1, 2014. Whether you get it through your employer, whether you get it through a public or a private exchange, we're going to talk about both of those here today, you must have insurance. But you as an employer of over 50 employees do not have a responsibility until January 1, 2015 to offer health insurance. We've got a variety of things that have happened inside the law, most of which right now are pretty innocuous. President Obama, every time he gets on a podium like this, likes to talk about all the wonderful things that the law has done. I would propose that the law has done very little for anybody at this point. If you're a kid age 26, yes, you can stay on mom and dad's plan. Very, very few people age 26 were insured on their own anyway, and very few of them need health care because that's the young, healthy generation. So has it helped? Sure, it's helped for some folks who graduated from college and maybe there wasn't a job available to them so they could get onto an employer-sponsored plan. 2013, we have W-2 reporting. We have a new thing called PCORI, which is the Patient-Centered Outcomes Research Institute. The government, in their wisdom, said as part of the law, they should research the efficacy of the law. Let's think about that. We already know the law's not working all that well. Maybe we should put an institute together and make the good taxpayers of America pay for it. Sorry for my political state there. PCORI is a pretty small fee. It's $1 for every belly button on your health plan. It's going to be collected for you by your insurance companies. If you're self-insured, you may have to remit that directly. 2014, the big news is in, what are we, the 18th of today, so 12 days from today, all of you will be able to go out onto the public exchange and shop for your insurance. I was talking to one of our guests here today, and he said he went out onto the exchange, and he's a pretty educated guy, frankly a CPA with probably advanced degrees, and he couldn't figure out how to do it. So the good news is that consternation that I had back in Hawaii about I'm going to be unemployed, it's pretty confusing. I think we're okay. We're going to need to help everybody. But as of October 1st, the public exchange comes online. Our good governor decided that Ohio would not, Ohio would not sponsor our own state-based exchange. We'll talk about that in just a few minutes. So we're going to have a federally sponsored public exchange. Guys, it's not the federal government providing your insurance on this exchange. It's the private insurance companies from which you already purchase insurance, Medical Mutual, Anthem. United Healthcare has actually taken a pass on the public exchange for now. They're going to enter into it later. But it's the same insurance companies. If you're buying employer-based coverage, you're going to be buying it from the same folks. The rates and costs are going to be nearly identical to that you will receive if you purchase it privately. The big difference is if you're participating in a public exchange, again, in Ohio, a federal exchange, you'll have access to subsidies. Real quickly, the individual mandate, if you choose not to follow the law as of January 1, 2014, you'll have to pay a tax. That tax starts at $95 per year or 1% of your income. So let's say you're a person making $45,000 a year. We're talking about $450 a year as a penalty tax. Anybody want to venture to guess the average monthly premium for an individual? Shout it out. Around $450, $500 a month. That's what we're expecting the exchange to be for a person in their kind of mid-30s. So the conundrum then becomes, okay, I'm an American citizen, the law says I have to be insured, but I'm young and I'm healthy and I'm currently not insured. Am I going to go out and spend $7,000 or $8,000 a year to avoid $450 in taxes? Probably not. So we don't think that there's going to be a major rush for those young, healthy, uninsured folks to go out and get insured. What we do think is there's going to be a huge rush for the not so young, not so healthy, uninsured who can't get insurance today to rush out to the exchanges. We're going to have something called anti-selection, where folks who need it really badly start to buy it because they've never been able to get it before. That's going to be one of the concerns. Shared responsibility, as we talked about, has been delayed. However, I think most people have attended or read or seen, it's pretty significant if you choose not to sponsor an employee-based health plan and you're over 50 employees. It's a $2,000 tax or possibly a $3,000 tax if your plan is deemed to be unaffordable. As an individual, you have to maintain what's called a bronze plan. What in the world does that mean? Well, it gets complicated. The bronze plan is based on something called a 60% actuarial value. Do we have any actuaries in the room? Good, because I like to talk bad about actuaries. Actuarial value, basically, if you think about $1 million of cost going into a plan, a 60% actuarial value would essentially be, in broad terms, 60% of that $1 million would be covered by the health plan. So you have to maintain a plan as an employee or an individual that has a 60% actuarial value. You as an employer, if you're over 50 employees, have to sponsor a plan with a 60% actuarial. Again, approximately 60% of the expense of the health insurance or health care costs borne by the plan. We're not going to go into much about minimum value, but the government has actually gone so far as to stipulate what must be covered in the health plan. So some of you may have casual employees or part-timers where you said, hey, we'll provide you a mini-med or a hospital indemnity plan. Those plans don't meet the minimums. So many of them, as a matter of fact, Aetna, large insurance company, has exited that business because they don't think too many folks are going to buy it. As we just talked, if you're over 50 employees, you have a responsibility to provide employee benefits to your employees or pay a tax. Many of the employers out there saying, okay, right now, we just saw that the costs for Americans is $8,000 a year for health care. I know as an employer, when I get my bill every month, it's a lot more than $2,000 a year. Why wouldn't every employer just say, I'm out, and go ahead and pay the tax and push their employees into the public exchange? I think the reason many employers that I'm talking to, and frankly I've talked to all of my clients at this point numerous times about this law, and with the exception of one, first time I heard it, nobody is anticipating abandoning the health insurance programs that they have now, because I think there's a lot of uncertainty, and there's this whole idea of trying to attract and retain good people. And I can imagine an interview going something like, you've got the best and brightest, you've got a young John Bonfiglio coming out of his master's degree program at the Weatherhead School of Business, and you say, hey, we really want you to come to work for us here at BSB. Tell me about your benefit plan. Well, that's a good question. We do the public exchange, and we're going to give you a couple $1,000s into your paycheck, and we're going to go ahead and pay a tax on your behalf. I'm going on to Deloitte Touche because Deloitte Touche is going to offer me a better benefit plan. So I think, again, a lot of employers who want to attract and retain good people recognize this is a way to separate yourselves. So I don't see wholesale adoption of the public exchange by too many employers. If you're under 50, the mandate doesn't apply. So I think we'll see more of those kinds of employers considering their options. The last thing we want to talk about it with regards to the shared responsibility, again, which is delayed, is the 9.5% rule. So the original legislation said that if you offer insurance to your employees, not only do you have to offer a minimum plan, it has to cover things like outpatient and inpatient and emergency room and prescription drugs and a whole host of things that it has to cover. It also has to be affordable. And they decided that affordability was 9.5% of an individual's income. And it actually started of 9.5% of family income, right? So about 2 months into the law, they realized, how in the world are these good employers going to know what the spouses of their employees make or potentially what the family's income is? So they deferred back to saying, okay, it's 9.5% of individual income. So first of all, they kind of wafered, but the other thing I want you to think about is 9.5% of your individual income, in the government's wisdom, they've decided you should pay 10%, roughly 10% of what you make towards health care, right? If you're borrowing on a mortgage, they do about a 25% debt to income ratio, so you can spend up to 25% of what you make on housing, right? They allow that for your mortgage. Now they're saying 10% of what you make is going to be spent on health care. That's a pretty scary number to me. There we talk about the 60% actuarial value. We're going to move on through that. So the last kind of little nuance, anybody in the room have more than 200 employees? All right, if you have more than 200 employees, as of 2015, you have to automatically enroll them in the health plan. That's the law. We're going to see some guidance. That doesn't take effect until the end of 2014. Now let's talk about transition fiscal relief. Obviously, this law is going to cost a lot of money. We're going to talk about the taxes and the revenue generation from our friends at BSB. We're going to talk about employer responsibilities as well. Employer exchanges. So there's two kinds of exchanges today. Anybody read the news that Walgreens, that was in the news this morning, actually, I think Mike sent it to me. Walgreens is now going to move into a private exchange, different than a public exchange. Public exchanges offer government subsidies. Private exchanges, and really right now we've got two very large retailers that have moved into that space. The first was Sears/Kmart. I think we all know Kmart and Sears are owned by the same holding company. They adopted a private exchange very early. Now Walgreens is doing that as well. The health insurance world is moving very quickly towards something called defined contribution. Anybody have a defined contribution pension plan? A 401k, right? So when we all grew up and our parents worked for Ford or GM or a large company, they had something called a defined benefit plan. They would retire and they would get a set amount of money per month. Many of your folks may be retired now. Some of you in the room may still have a defined benefit plan. But because of the aging of America, because of the poor performance of the market, because of some actuarial statistics, we've moved away from defined benefit plans by and large towards something called a defined contribution plan. Many of us, probably the vast majority of us in this room, our pension is going to be from a defined contribution 401k plan. Health insurance is moving very much the same place. So these private exchanges will be based on a financial model called defined contribution, very much like the defined contribution in your pension plan. Employers will say, okay, here's what I can afford to pay on a monthly or a quarterly or annual basis for your health care. You, as an employee, will be needing to pay the rest. Again, we defer back to that 9.5% of your income. Let's say your employer pays half of that. Now we're fortunate that we may be only going to pay 5% of our income, our gross income, towards this. So today, public exchanges are a conduit for a subsidy, but private exchanges, there is no subsidy. We are continuing to hear that there may be some subsidies available for folks to participate in private exchanges, but as of now, the only way to get a subsidy is to participate in a public exchange. We talked about bronze. There's two other metal plans, silver and gold, as you might guess, as well as there's platinum. Very few employers are going to be offering a platinum plan, but bronze, silver, and gold will be the standard upon which all the plans will be judged. The bronze plan we talked about, 60% actuarial equivalent. Silver will be a 70% actuarial equivalent. Gold will be 80%, and then platinum would be 90%. Let's take a quick look at the subsidies because they're fairly significant. Again, our friends from BSB are going to talk about the revenue generation side of this. This is a very, very expensive law to implement because the vast majority of people who enter into a public exchange will receive a subsidy. For a family of 4, you can earn up to $92,200 and still be subsidized by the federal government. As you can see, with Medicaid expansion, there's a big blue question mark there because in Ohio, we haven't decided whether we're going to expand Medicaid or not. The governor is in favor of it. The legislature is not. So they're still battling over that. I don't believe it's going to get done in this budget, so we probably won't expand Medicaid at least this year. But as you can also see from this chart, a lot of us would be receiving a subsidy based on family income regardless of Medicaid expansion. So how am I going to find out and learn about the new health insurance marketplace or exchange? The law has given birth to this new concept called a navigator. I've been in the employee benefits business for not quite 25 years. I can't be a navigator, right? Because I can't earn a commission or a fee to place your insurance and then also be paid to help you navigate the exchange. I have to choose either or. So what we're going to have is the navigators that are entering into this business are folks that are coming from outside the industry. So not the most expertise because the navigator plan it's not a real lucrative plan for folks who advise. So you're going to see nonprofits, churches, organizations entering into navigators. I think it's going to be, if you think about the cable company meets the DMV for customer service, right? That's what the exchanges are going to be like. And you're going to need a lot of help. Health insurance exchange status, Ohio. Our program is going to be federal with state assistance, as we talked about. The single premium for a bronze plan, $282.51 is an estimate. As you can see, Aetna, AltCare, Humana, Medical Mutual, all have agreed to participate. There are 14 insurers in Ohio who will participate in the plan. I don't know if you've followed what the president is saying, but he's actually telling us that costs in the insurance marketplace are going to be lower than they've traditionally been. That may be true in California and New York, where insurance is very expensive. It is not true in Ohio. Trust me, I deliver renewals to my clients every day, and these renewals are ranging from the low end in the 20s. I have a client right now who's gotten a 59% increase to their health insurance costs. So I don't expect it to be very affordable. The underwriting model is changing. We'll talk quickly about the underwriting model. So private exchanges, we talked about limited participation to date, but bigger and bigger employers are entering into these defined contribution private exchange marketplaces. Medicaid expansion. So the idea behind Medicaid expansion is that we would expand Medicaid to go 130% of poverty. Right now it's 200% for kids. So kids are insured inside a program called CHIPRA. There's not a lot of traction in the legislature. If you talk to the folks that are opposed to it, their concerns are around two things. One, it's going to put a lot more people on kind of a public assistance type health insurance program. They're not looking to expand the roles of folks who are dependent on our government. And then two, the Fed funding for the expansion is only a 2-year deal. So we could agree to expand Medicaid, do that, get Fed money for 2 years, and then the Fed money theoretically, depending on the economics of what goes on in the federal budget. Anybody confident we're actually going to have a federal budget? Things could change in a couple of years. So I'm kind of on the fence as well. Medicaid expansion is great for the hospitals and the providers. They need our help. But I don't think it's great for us as taxpayers because it could end up being an unlimited kind of wallet. At this point, Mario's going to talk a little bit about employment relationships.